Hello and welcome to today's webinar. I'm Cheryl Blair, the Audiology Advisor at AXOPA. This afternoon, I will review the revised hearing screening guideline and protocol that has been recently approved by Council and posted on the AXOPA website. Mackenzie, if you haven't already, please go ahead and add the link to the hearing screening guideline to the chat. Thank you for that. So a few housekeeping notes before we get started. Just know that your video and mic are turned off and will stay off for the duration of the presentation. However, the chat feature of Teams is available to you to make any comments or ask any questions throughout the presentation. And although we may be able to answer some of the questions as they're posted, we may not get to all of them until later in the session. And there is dedicated time at the end of the presentation to take questions and to have a discussion. Now, you know, all the things you prepare for. There we go. Sorry about that. So in today's webinar, I'll go over the revised hearing screening guideline to familiarize you with the key elements, to note any changes we've made to the guideline from the older version, and of course, to allow time for questions and discussion. And before we begin, again, I just want to point out, you might have already noticed that the hearing screening guideline is a guideline and a protocol. So why is that? And what is the difference? So just to review, a guideline is a document that supports the clinical application of a relevant standard of practice, which is the minimum expected performance. So the guideline provides some detail to ensure that the minimum requirements are being met. A protocol, on the other hand, specifies how regulated members should perform a particular activity in an area of practice. And the hearing screening guideline and protocol is a guideline with a protocol embedded within. So you can see from this example, this is a clip of the table of contents, and the protocols for hearing screening are in the appendices, and they include a step-by-step process to follow for each activity. Now, here's a clip from a guideline portion of the document, and you can see there are still instructions of how to perform the activity. However, they're not as detailed as they would be in the protocol. Okay, so let's take it from the top and go through the highlights of the current hearing screening guideline and protocol. The goal of the hearing screening guideline remains the same. So it is to identify individuals, children from age 3 years to adults, most likely to have peripheral hearing loss that may affect everyday communication, educational success, social, language, and cognitive development, and/or integrity. The current hearing screening guideline reflects best practice methods as described by the American Speech Language Hearing Association, the World Health Organization Report on Hearing, and the World Health Organization Hearing Screening Considerations for Implementation. And Mackenzie, you can put those links in the chat box if you would. Thank you for that. Okay, so starting out, the first section of the hearing screening guideline discusses designing a hearing screening program. So just for your information, these are the elements involved if you were ever interested in designing a hearing screening program. In Alberta, other than the newborn hearing screening program, there are no formal hearing screening programs, say, for example, for kindergarten or school-aged children. If one were to be designed, SLPs could well be involved in the development of the program in consultation and collaboration with audiologists. As we know, however, most hearing screening in Alberta is done outside of a formal organized program and is often carried out by speech-language pathologists as part of a speech-language assessment, for example. Speech-language pathologists may be doing the hearing screening themselves, or they may be supervising support personnel and/or speech-language pathology students who are performing the screening itself. So throughout the document, it's recommended that speech-language pathologists involved in hearing screening have access to an audiologist who can provide consultation, support for any troubleshooting issues that may arise. And we know this is perhaps challenging if someone is working alone, if a speech language pathologist is working alone or with other speech language pathologists only. However, I do recommend reaching out to a local audiologist just to establish that collaborative relationship if you can, just in case. So moving on, just along the document, a few notes, something to note on page 8. The hearing screening guideline makes a distinction that informed consent for hearing screening must indicate that the consent is for hearing screening as opposed to a hearing assessment. Also on page 8, there is a list of contraindications for hearing screening. So for example, if a client has a contraindication list that is listed here, you do not need to proceed with hearing screening, but instead refer to an audiologist or a physician as indicated on the list. You'll notice that SNHL stands for sensorineural hearing loss, sudden sensorineural hearing loss. I'm missing an S there. For sudden sensorineural hearing loss, you want to refer to both a physician and audiology. That would be an urgent referral. So unless there is active infection with drainage, for example, there really is no harm in proceeding with a hearing screening, but it's just not necessary. If your client is already under the care of an ENT specialist regarding their hearing and or under the care of an audiologist, again, hearing screening is not required. So let's talk a little bit about training. So on page 9, the hearing screening guideline indicates that screening personnel, so either support staff or not support staff, but support personnel or speech language pathology students must be trained and supervised. The supervision can be carried out by a registered audiologist and or registered SLP who has training and experience related to the screening test procedures. So I just want to be really clear here that speech language pathologists who are involved in hearing screening and are familiar and comfortable with performing this activity do not need to be supervised by audiologists. It's just recommended, once again, that SLPs do have an audiologist they can reach out to for any consultation, troubleshooting, any issues, any questions, just to have somebody that you know you can talk to if something arises is recommended. So having said all of that, is there any training that needs to be delivered by an audiologist specifically? So let's talk about otoscopy. To perform otoscopy, SLPs and support personnel must be trained and supervised by an audiologist, as otoscopy is an activity restricted to audiologists. So as per our standards of practice, Mackenzie, if you could put the link to that standard in the chat. As regarding the standards of practice 6.2, regarding the supervision of restricted activities.
Cheryl, I don't want to interrupt, but there's a question in the chat from Crystal. She just wanted to know on the last slide, can you clarify what head injury includes?
Sure. Let me go back to that. Thanks for that, Mackenzie. I actually don't see the chat on my screen, so I appreciate that. Head injury, I don't think you have to go into that in detail. If a person reports that they've been hit on the side of the head and they experience tinnitus or some loss of hearing, you just want to ask those expanding questions during the case history. Concussion, maybe. I would take caution there, and if someone reported a head injury that required hospitalization, then for sure you want to refer that person to audiology. If they indicate that after a blow to the head they felt there was some hearing loss, they didn't hear quite as well, I would report that to audiology, or refer that, I mean. Does that answer your question? Let's just see if I can. Is that good to go?
Yeah, Cheryl. Crystal has said yes, thank you in the chat.
Thank you.
We also have 2 more quick questions. Would you like them now, or would you like to deal with them at the end
Yeah,
of the
why don't
presentation?
I think we're moving along quite well. Let's go ahead and entertain those questions.
Yeah, Cheryl is curious, can SLP assistants train and supervise students performing hearing screenings?
Can the SLP students supervise?
Can SLP assistants train and supervise students?
I would say no. Susan, do you want to pipe up on that? Chime in?
Sure. Sure. Hi, everyone. It's Susan Raffett, registrar. In that case, while an SLP assistant may be able to support an SLP assistant student in doing these kinds of things, ultimately it would be the SLP who has the ultimate oversight and responsibility in that situation. So they need to know what's going on. They need to have a comfort level that the assistant has the competency and the capability to provide some guidance to the student. But I think that the SLP themselves also needs to be aware of the situation, have their eyes on the situation, to know whether or not this is an appropriate way to proceed. Hope
thank
that
you.
helps.
Yeah, thank you for that, Susan.
Cheryl says thank you. And we also have a question from Carla. Abnormal appearance, does that include ear tags?
Yes, and so there's more detail to this list on page 8 of the guidelines, but yes. Now, if you see that, you can always ask if that person has been to audiology and had an assessment prior based on that ear tag. And if the answer is yes, you can proceed, but you may not need to either because they've already had the assessment if the assessment was normal. So you just kind of have to ask those expanding questions and use your common sense, use your judgment. And again, unless there is active inflammation, drainage, or pain, it doesn't hurt to proceed with the hearing screening.
Carla says thank you. I think that is all of them for now, Cheryl.
Okay, thanks. So I apologize for my lack of technical prowess here. I should have the chat in my view, and I just don't. So thanks for your support, Mackenzie. Okay, so back to otoscopy. That was just going over the standards of practice. And I just want to have a look at this issue a little more closely. So the actual activity that is restricted to audiologists is the insertion of the tip of the otoscope beyond the cartilaginous portion of the ear canal. So what if the placement of the otoscopic tip into the ear canal is done in a shallow manner? And most likely that is fine and does not fall under the definition of a restricted activity and therefore would not require supervision. However, training is required initially to ensure that even this is done correctly. For example, how shallow is shallow? Remember that a shallow placement is different for children than for adults. Also, some questions you might want to ask is, what is the proper technique for otoscopy? How do you hold the otoscope? How do you brace effectively? Bracing is super important. A lot of people forget that part. It's also important that an audiologist be consulted for training if otoscopy is what you intend to do and you've not already been trained. Now, many of you have been trained at some point. And even so, if you've been trained and feel competent in performing otoscopy, once again, it's recommended that you have an established relationship with an audiologist, if at all possible, in order to be able to consult with them when and if you feel you need to. And for those of you who know how to do otoscopy, but want to remind yourselves of proper technique, there's a short YouTube video I found on how to perform otoscopy by Dr. O'Donovan. And Mackenzie's going to put that link in the chat for you. And that just goes over, it's a very brief video, but is very comprehensive in going over how to perform otoscopy if you want a review.
And we just have another question in the chat, Cheryl.
Yeah.
Lisa is wondering, does AXLPA have avenues for SLPs to receive training from audiologists to perform restricted activities? Wondering specifically about otoscopy and tympanogram, working in remote location where access to audiologists and physician services are limited.
Right. So we don't have anything formal set up. I would recommend that you reach out to the audiology community and try to find somebody that would be willing to do that for you. And unfortunately, that's all the advice I have on that at this time.
Lisa says, thank you. And Jenna is wondering, is it appropriate for the SLPA to ask the screening questions? And in brackets, they've put the contraindications without the SLP present.
So in considering that, I would say it depends on your comfort level with that screener. Taking a case history always involves expanding questions, especially on those sticky areas that pop up where you need to know a little bit more before you proceed. If you've trained the screenee in doing that, I don't see a problem. And again, keep in mind that the only time we want to ensure that the screening does not proceed is if there's pain, inflammation, or active drainage. Otherwise, even if there is a contraindication and the screening is done anyway, there's no harm, no foul. It's just a bit more time than was necessary. Is that an adequate answer for you? Does that answer your question?
Jenna says, thank you. And that is all the questions I see for now.
Okay. Thanks for your questions and for engaging in the conversation here.
Cheryl, it's Susan here. If I could just add to that a little bit, I agree with your commentary. And I would just say, like many things that we give over to assistants, our guideline for working with support personnel talks about the fact that you kind of need a flow sheet. So if there's any chance that you're moving into an area where there's going to be interpretation that goes beyond a real concrete yes or no, then likely what's going to happen is the assistant's going to need to stop and go back to the speech pathologist for clarification. So I think what Cheryl was saying, it may be that you get a very clear yes or no, and then you know how to proceed. When in doubt, though, the assistant needs to stop and needs to be coached to stop and to speak with the appropriate supervisor. So just wanted to clarify that a little bit more, but I think we're on the same wavelength with that one.
Yeah, thanks for that, Susan. This guideline actually refers to numerous other guidelines, so I really appreciate you chiming in on that. Okay, so 2 more points that are covered in this hearing screening guideline. Typically, we screen pure tones of 1,000, 2,000, and 4,000 hertz. And what about 500 hertz? We do know that the frequency of 500 hertz is important for understanding speech, and that testing at this frequency is required to identify low frequency hearing loss due to middle ear disease or progressive sensorineural hearing loss. That's not, that's just what we know for a fact. However, there is a high risk of overreferral to audiology when screening at 500 hertz, as this frequency is harder to hear and is more likely to be masked or obscured by background noise. This is especially true when testing outside of a sound booth and or when using over-the-ear headphones rather than insert earphones. So to minimize over-referral to audiology, the current guideline recommends including 500 hertz when screening only if you are using a sound booth and or if you're using insert earphones. Moving on to 6,000 hertz, the current guideline recommends that 6,000 hertz be included when screening older children, teens, and adults in order to be able to screen for any noise-induced hearing loss. And just a reminder, if you are using insert earphones, you will need to perform otoscopy. But keep in mind, you do not need to test at 500 hertz. You do not need to perform otoscopy and use insert earphones, and you do not need to have a sound booth in order to perform hearing screening. It is acceptable to leave 500 hertz out if you do not have these things in place. Any questions on that? Okay, let's move on. So on page 10, you can check out the section on audiometers. The guideline provides a detailed description of equipment and how to maintain and care for it. This current guideline recognizes that it's no longer necessary to stick to using actual audiometers. It is acceptable to use audiometric software that is in compliance with ANSI standards and downloaded to your laptop in order to perform hearing screening. And this may be good news for some of you who are struggling with old, cumbersome audiometers, or who would like to start hearing screening but find the process of using old equipment to be too burdensome, or acquiring new equipment to be overwhelming or too costly. Just a note that whichever you use, equipment or audiometric software, both require annual calibration. And this can be done by technicians certified in calibration in the case of equipment, or by contacting the manufacturer of the software you've purchased, who can provide the calibration update online. And just another note, your headphones or your insert earphones that are calibrated to the equipment or the software needs to stay with that equipment or the software. You can't switch them around. They are part of the overall calibration of the equipment or the software. Okay. On page 12, there's a section on the screening environment, what room are you going to be using, and what are acceptable background noise levels. How do you evaluate room levels, both subjectively and quantitatively? Both are addressed. So, for example, you can use a sound level meter or a sound level app to measure noise levels in the room. And you can also evaluate the noise levels by conducting a listening check, paying particular attention to ambient noise that is generated by fans, air conditioners, and the like. Please note that you don't need to do a highly accurate sound level survey of your environment. A mindful estimation of the background noise levels, which is what you will get if you use a sound level app or a listening check, should be adequate. And a rule of thumb you can use is that if the hearing screener has normal hearing and can hear the screening tones through the headphones or the insert earphones, then the screenee should also be able to hear the tones if they have normal hearing. Okay, tympanometry. We all know that it's very useful to detect middle ear issues. The World Health Organization recommends that tympanometry be performed as part of hearing screening. ASHA supports the use of tympanometry in younger children to indicate conditions that require medical referral. And the Global Burden of Disease study from 2019 did indicate that most hearing loss for children under the age of 5 years was linked to the presence of otitis media.
Hi,
Now,
Cheryl. We just have another question from Andrea. Do you have any comment on the use of the Hear Who app?
Yeah, that's coming. I'll just set that aside for a second, Andrea, and get back to that. So, having discussed all the recommendations for including tympanometry, we also know that it is not typically performed with hearing screening in Alberta, and that is fine. It does not have to be included in your hearing screening, and in fact should not be included unless the screener has the clinical competence to perform both otoscopy and tympanometry safely. So, Andrea, I'm just parking your question, but I haven't forgotten about it. Okay, so we all know top of mind in hearing screening is that we want to minimize over-referrals to audiology that place a burden not only on the healthcare system, but also on families. So one fairly easy way to do this is if the outcome of your hearing screening is a fail, if you take the time to reposition the headphones, to re-instruct, and to rescreen all within the same appointment, the American Academy of Audiology in 2011 did find that using this strategy reduced unnecessary referrals to audiology by at least 25%. Okay. So we've covered the highlights of the hearing screening guideline, and I just want to take a minute to summarize what is different or what has changed from the previous guideline. And just to note that some of the changes are more of a different emphasis rather than complete differences. So let's go through them. The revision of AXIPAW's hearing screening guideline was undertaken to address currency of content, which is something AXIPAW does for all of the documents. And then this revision took regulated members' feedback into account regarding current practice issues, inclusion of current technology, such as the WHO, what's called Hear Who app for adults, and the desire for a user-friendly format for ease of use. Okay, I'll summarize the changes in each of these areas in the next slides. So regarding current practice issues, the role of the audiologist and the SLP in designing a hearing screening program is clarified for reference if this was ever to be developed. So currently, it's just sitting there, but if anybody thought, you know, let's develop a hearing screening program for school-age children, then the roles of the audiologist and the SLP can be found in this guideline. This document is very clear about screening 500 hertz only if you've got a sound booth or you have insert phones in order to minimize over-referral to audiology. And it also talks about recommending inclusion of 6,000 hertz in the screening for adolescents and adults. The current hearing screening guideline also puts less emphasis on the use of insert earphones for general hearing screening. Using over-the-ear headphones is just fine. It also notes that otoscopy is only required when using insert earphones and must always be performed when using insert earphones. And again, the use of insert earphones in otoscopy is not necessary in order to move forward with hearing screening. This document.
Hey, Cheryl.
Yep.
Marie has a question. If you are unable to rescreen same appointment, is it acceptable to rescreen later that day or another day?
Yeah, I mean, for sure. I think ideally, if you could get it all done in the same appointment, it saves time. It's more efficient if you can possibly fit that in, but I understand that that's not always the case. It's not a protocol. It's just a recommendation, knowing that that strategy does minimize the over-referrals to audiology. And if you're right there, the child is prepped, ready to go, everything's set up, if you can do it in the same appointment, that's just more efficient and probably a little easier on everyone, understanding that that's not always possible. Does that answer the question?
Yes, thank you.
Thanks. All right. So this document also emphasizes ensuring that a hearing screening should be done with, before, or very shortly after an initial speech language assessment. So hearing screening is considered to be part of an initial speech language assessment. This version of the hearing screening guideline also notes that pulse tones or warble tones may be used in hearing screening. I prefer pulse tones. There is evidence that these tones are easier to hear than just a steady state tone. Most audiometers offer this option, so you may want to consider that. And in this document, there's a bit more detail included regarding documenting hearing screening results. So on to the developments in technology, which include the Hear Who app. One thing that we've already covered, which I think is good news, is that it's no longer recommended that you just stick with standard screening or diagnostic audiometer equipment. Only you can go ahead and use audiometric software that is up to ANSI standards, or meets ANSI standards. We know that reliable and validated audiometer software is now widely available. And the use of ANSI standard software on desktops, laptops, tablets eliminates the need for traditional portable hearing screening equipment. And so on page 19, the hearing screening guideline does discuss the use of technology-based screening tools, such as the digits in noise apps, which is Hear Who and Hear Who Pro, for screening hearing for adults. I don't really have anything more to say about that unless you have more specific questions. It certainly is acceptable to go ahead and use those apps with adults. Okay, so the last category of changes or change in emphasis is regarding the user-friendly format. The changes that we've made to achieve this are grouping the references and providing them at the end of the document rather than throughout. We've included Appendix A as a checklist of how to perform hearing screening. Appendix C is a flowchart depicting the hearing screening referral protocol. Tympanometry is briefly discussed. Audiologists and speech-language pathologists are referred to ASHA guidelines if tympanometry is to be included in a hearing screening program. And otoacoustic emissions are not mentioned in this hearing screening guideline to simplify the document, as this test is not typically included in hearing screening of individuals 3 years and older. So when we sent out the request to our regulated members to review and comment on the revised hearing screening guideline before it was presented to council, we had a lot of feedback, which was awesome. A lot of the feedback was, we took it back to the committee and addressed issues that were brought up. And a lot of the positive feedback from the membership survey indicated that the updated version is clear, concise, and includes comprehensive rationale, that it addresses the methodology that leads to over-referral to audiology, and that it notes that hearing screening is an integral part of a speech-language assessment. So those were specific comments made by the members. Okay, so we've come to the question part of this presentation. And I'm just going to go back and pull up the chat so that I can see the questions. And are there any questions? Are there any concerns? Are there any situations that you'd like to bring up for discussion that haven't already been brought up? Any points that you're still not clear about? Okay, well, while I'm giving people a little bit more time to do that, I do want to show you the QR code that you can go to in order to complete our post-webinar survey. Give me a second here.
We do have a question that just popped up in the chat. Krista
Okay.
is wondering, what age would you recommend including the tone at 6,000 hertz?
You know, it depends on what you read. Some of the literature is indicating that noise-induced hearing loss is starting at earlier and earlier ages. I personally would probably just include it, say about age 8, 9, 10. I mean, it just takes a few extra minutes to do that. 10 for sure, I'd probably include it. 12 for really sure. SLP assist, does that answer the question, Krista? Yeah, okay. So Penny, can SLP assistants train and supervise students performing hearing screenings? That's more to do with the guideline on supervision, and Susan Raffett had an excellent response to that question. So Susan, can I call upon you again to discuss that?
Yeah, sure thing. So what we had talked about was that if you have an assistant who's competent in performing hearing screening and you want them to work with the student, the SLP assistant student, that's probably fine. But ultimately, it is the speech language pathologist who has oversight and accountability for ensuring that that all is going well in that regard. And so I would suggest that at a minimum, the SLP should have some eyes on what's going on, knowing that they have a comfort level with how the SLP assistant is guiding and training that student, perhaps providing a few pointers themselves. And then if they're feeling comfortable that that can proceed, that's fine, knowing that the assistant and the assistant student can always come back to the SLP for clarification and support.
Okay, is that good, Penny? Okay. So, any recommendations on apps to use with preschool population? You know, I don't recommend using apps with the preschool population. I don't think there have been any that are validated. I'm not so sure that would work with that population. Does anybody else have any information or comments on that? I've not read anything along that line. Have you? So I guess the answer to that question is, okay, over-referrals to pediatric children are simply unengaged. Yep. Oh, okay, let me just read that out. I feel that over-referrals for pediatric clients are often children who are simply unlikely to engage in the task. If these children have been screened as newborn, could we postpone this piece of assessment until we feel the child is likely to complete the task? Yeah, personally, I would refer to audiology in this case. Most likely there is a way to engage. An audiologist can get something along the lines of an audiology assessment. I wouldn't postpone it if it could be that hearing loss is affecting speech. I would refer. So, wondering if any SLPs have added tympanometry and Autoscopy to their screening practice and share some of their thoughts on the value of this. Is there anybody that would like to respond to that? Is anybody doing tympanometry and Autoscopy and want to talk about that?
I'm thinking as well in response to that question, because it may take people a bit of time to pull together their info on that. We could certainly, if people have some insights or thoughts on completing otoscopy and tympanometry, please feel free to share that information. I would say with Cheryl, you have her email address, and we could certainly perhaps think of a way to share that information or to pass it along to Lisa if there's some specific feedback.
Okay, thank you, Susan. So for some reason, I can't seem to get to the next slide, so I'm just going to move the post-webinar survey code, QR code, into your visual. Can you see that? Mackenzie, are you able to see the QR code?
Yes, we are.
Awesome, awesome. More than one way to do stuff. For the hearing screening apps, can they be used with standard earphones, earbuds, over-the-ear headphones, or AirPods? Is there a specific criteria surrounding the headphones? Not that I know of, but I would look into that in terms of if you're going to use that app, there should be instructions that come along with that app and would let you know. So the more high fidelity, if you will, the transducer or whatever you're going to use to deliver the signal, the more accurate the test. But keep in mind, these are screening apps, hearing screening apps for adults, and not really the same concern about over-referral to audiology, perhaps, as with children. But the first thing I would do is have a look at the instructions of the app. It should let you know. Anybody else have any different information to give?
There was also a question, just one up from that, Cheryl, from Laura.
Cheryl, did you recommend that all preschoolers and younger be referred to an audiologist versus being screened? If you can't do the screening, so was that referring to your previous question? If they were not able to engage in the task? I might be crossing wires here, but if a child cannot engage in the hearing screening task for whatever reason, then I would refer that child to audiology. Does that clarify it, Laura, or am I missing something?
I would just say, it's Susan here again, Cheryl, and I would just say I completely support your comments in that regard. I think what we're trying to say there is we make attempts and we do what is reasonable, of course, but if there are very difficult, challenging to test children and we continue to have concerns about their hearing ability, then it is incumbent upon us to make those referrals. That should not be misconstrued as an excuse to not do a hearing screening. I think there needs to be an attempt to do hearing screening, of course, but we know sometimes there are children for whom that is going to be, you know, very, very challenging. And audiologists, pediatric audiologists in particular, are probably in the best place to manage that. I don't know if you would add anything to that, Cheryl.
Yeah, I mean, it's definitely conceivable that there are some children that require a little extra to have their hearing tested. And you can attempt the screening, absolutely. If you really can't get through it, I wouldn't wait. I wouldn't leave it. I would refer. Do I recommend that a hearing screen be completed with all adult seniors doing a communication assessment? Oh, you know, I don't know. At that point, I would say, just thinking about it in my mind, adults should be able to tell you if they're struggling with hearing. But given that we have these apps that are so easy to use, I mean, it's not a bad idea to go ahead and do that. Some people may not be open to wrapping their heads around that they have a hearing problem yet. But at least that would give some, I guess, grounds for saying, you know, I really recommend you have a hearing test done. If we don't have an audiometer for screening, then we should not do screen on preschool children. What does that mean? How else would you do it? Sorry, can you explain, Lana? To do a hearing screen for children, you would need an like an audiometer or audiometric software. I think I'm just not understanding your question. If you wouldn't mind elaborating, that would be helpful. Said not to use apps with children. So what we use? Oh, okay. So the apps I'm talking about are just, you know, you can download them on your phone. They're digits and noise is what they're called, digit and noise hearing screening, and they're meant to be used with adults. So with children, teenagers, you would want to use audiometric software. You'd actually want to give them a standard hearing test with an audiometer or software that you can download onto your laptop, which is different than the apps. Does that make sense? So audiometric software on your laptop would allow you to actually present tones and and the intensity levels. And with respect to recommending software, no, I don't have any specific recommendations, but when you're researching it, you just have to be aware that it needs to be meeting ANSI standards in order to be something you'd want to use. Jillian, should not be the expectation that the private SLPs and private SLP organizations have to purchase the appropriate equipment to screen the clients they are servicing and not refer to public health for screening, except for those they have not been successful screening. I mean, sure, whenever possible. I mean, I can imagine there'd be scenarios where that just isn't going to be the case for one reason or another, but generally speaking, absolutely. I agree with that. Hi, Holly. Is it still advisable that adults be screened with the older known hearing communication handicap surveys, especially in the absence of equipment? Yes, that's covered in the hearing screening guideline as well. Of course, I'm not going to be able to find the page, but it's in there. Thanks for that. Any other comments or questions? We still have a few minutes. Okay. Well, if that's it, I just want to, Jillian says, encourage if you're screening adults to understand pathways for referrals in your area. Yeah, good point. So Appendix C talks about the referral process, and Jillian is just advising if you are seeing adults, if you are screening their hearing, really great to have at the ready advice for them to where to go to have their hearing assessment done. Good point. Okay, well, I really appreciate the back and forth and the questions and the comments and suggestions. It's been a great turnout and great engagement. Thanks so much. If there's nothing else, we'll wait another minute. And if there's nothing else, oh, Megan, AHS has adult hearing screening guidance. Awesome. Please reach out to me if you'd like to see it. It aligns with ASAPA. Nice. Thank you, Megan. That's awesome. I'm glad, Brianna. You're welcome for the information. I really hope it's been helpful. And you know, if you think of something after the webinar closes down, please feel free to reach out to me. You can email me at cblair@axopod.ca.